Thank you for coming here today. The first question is about the thrombus. There have been long-term debates regarding potential benefit of thrombus aspiration during primary PCI in STEMI patients. What is your opinion? Which is better, the routine aspiration versus the selective aspiration versus or no aspiration?
Yeah, so thrombus is currently certainly the initiating event for myocardial infarction, and so we almost always have thrombus there of some sort. But sometimes the thrombus has been dissolved and the flow has been restored. Sometimes it's very bulky thrombus, sometimes it's very little thrombus. So the studies that have shown different outcomes maybe are influenced by these kind of events. So some of the studies that looked at thrombus aspiration using a very powerful device, mechanical devices, have not been very successful, but the aspiration thrombectomy, sucking the thrombus out, in general has been, and the guidelines have recommended now that thrombus aspiration be done in the setting of acute myocardial infarction. Only recently we see, when we try to measure whether that influences the total infarct size, we see the recent study that showed that it did not, which is surprising because it improves the flow initially, sometimes it improves the frame count, the velocity of flow, but it does not seem to influence the ultimate size of the infarct. I don't think we've got the final answer to this because I believe that if a lot of thrombus material is embolized, it probably does influence the outcome. So in my own practice, I recommend that we do thrombus aspiration, certainly if there's total occlusion. If the artery has already reopened and there's good flow, TIMI-3 flow, then I'm not sure how much the thrombus aspiration adds to the picture. But if the artery is still initially totally occluded, if there's bulky thrombus, it just is intuitively makes sense to me that I should aspirate that thrombus. It doesn't seem to be any downside of it. But I don't think we have identified cleanly the patients that benefit most from thrombus aspiration and the ones where it probably doesn't make any difference. That's work yet to be done.
So in your routine practice, you do the thrombus aspiration like this way, or?
Routine practice, if there is a totally occluded artery in the setting of STEMI, then I do always do thrombus aspiration. Past the wire, usually you get some antegrade flow with the wire, sometimes not. First thing that I do then is do the thrombus aspiration. On the other hand, if it's a STEMI and the artery has already reopened at the time, there's high-grade stenosis, but there's a normal flow, I'm not sure the thrombus aspiration is helpful or necessary.
Thank you. And then the second question is about your lecture. What is your strategy about the selection of revascularization in the stable ischemic heart disease?
Well, revascularization in the setting of STEMI is well established, and we've just talked about that. In stable ischemic heart disease, it remains a controversial area in two fronts. One is are stable ischemic patients benefited from revascularization at all, particularly ones with rather mild disease and not so much ischemia. And those questions all arise from trials such as the COURAGE trial and the Barry 2D trial and so forth. On the other hand, there's evidence that patients with the most ischemia, such as seen in the COURAGE trial in the nuclear substudy, or in the Barry 2D trial, where the most severely diseased patients did benefit from revascularization, or even from some of the newer attempts at measuring medical therapy versus revascularization. There's one called FAME-2 that was stopped prematurely. I object to that. I'm sorry it was stopped prematurely, but it was because the PCI group was benefiting mainly from avoiding the need for urgent re-intervention. So there's a lot we need to do about establishing whether stable ischemic disease can continue to be managed medically or it should be managed with intervention. And the new trial, Ischemia, is going to be addressing that. It's a tough trial, hard to do, because in that trial the patients will be randomized before angiography. So here's an ischemic patient. They've got positive stress tests, they have angina, and then the selection is if they have enough ischemia on nuclear perfusion studies, if they have enough ischemia, they are randomized. If they're randomized to medical therapy, they get only the medical therapy. They have no catheterization. If they're randomized to revascularization, they have catheterization, and then they have revascularization, which could be either PCI or surgery. So this question of do we do revascularization in stable disease is still under investigation. My view is that if you have a lot of ischemia, you benefit a lot from revascularization. If you have angina, you clearly benefit from PCI. Do you benefit from survival? It's going to depend on how much ischemia you have. That's my view. It's not proven. Now the second point is what revascularization? Should it be surgery? Should it be PCI? And to that end, now in the days of drug-eluting stents being the standard of care, most of our information comes from randomized trials, certainly with left main disease. It comes from things like the Syntex left main group, the pre-combat trial from here that's both shown that properly selected left main patients do very well with PCI. Patients with very extensive disease in the Syntex study do better with surgery. So these have been very helpful in helping us select therapy. For multivessel disease patients, same thing. Patients with low Syntex score, with reasonably approachable lesions do extremely well with PCI as well as surgery. Patients with more complex disease do better with surgery. So these kind of investigations are really helping us deliver the best care to our patients at the present time. As we go forward and technology improves even more, this will change because the guidelines at one point said left main should never be done. Thanks to contributions mostly from Korea, we have moved to saying no, it's can be done very successfully in certain patients. And the same may occur in multivessel disease with stable ischemic syndromes who require revascularization. So we have two issues. One is medical therapy okay for some people versus revascularization? And if you're over here in the revascularization group, which revascularization? So this is a fascinating area that's we're learning more about, and we're not at the end of the story.
How do you expect, when do we get the result from this ischemia study?
Oh, the ischemia trial is just getting started, and it's going to be a long time. It'll be several years. Probably, I think probably the first results from that, I think it's a 5-year average follow-up, will be 2015, 16, something like that. There's one other study I should mention that's going to be coming out this year, and that is the FREEDOM trial. FREEDOM is strictly in diabetic patients. Diabetic patients with multivessel disease who are randomized to drug-eluting stent or surgery. So this will be the most definitive trial looking at diabetic patients as far as the selection of which revascularization.
It must be very interesting.
And that anticipate will be reported at the American Heart Meeting in November.
Great. We are expecting the result. As the editor-in-chief of major cardiovascular journal, what issue or topics should be more answered from the future trials in this field?
Well, you know, we talk about how to publish the papers, and the way you get published is you have the best trial, the best study in the first place. So this is the key ingredient is not so much coming from the journals, it's coming from what is the project? Is the project truly valuable? So I'd like to think about that with you for a minute, because where have we been with our trials till now? Partly because of industry interest, we've been studying very large populations to find out questions like, okay, who with stable ischemic disease should go for surgery or PCI? Which patient should have routine anticoagulant therapy versus new 10A inhibitor therapy? And these are applied in very large populations. Prevention with statins versus not, and so forth. I think we're nearing the end of an era where we try to do these trials of 10 and 15 and 20,000 patients to achieve statistical significance. Mm-hmm. Because those trials, if it requires that many patients, then the clinical benefit has got to be fairly small. So I think we're going to be shifting to trials, and I believe industry will be supporting this, to shift to trials that will look at subsets of patients where the predicted clinical benefit will be much greater, and therefore the trial size can be smaller. Mm-hmm. Right. The number of patients enrolled can be smaller, mm-hmm. but focus on something that could have a greater clinical impact. You can think of things like patients with who are highly subject to thrombotic events, and you have some antithrombotic therapy, and you study that group rather than everyone. The prevention trials in cardiovascular disease, if you study primary prevention in the broad population, I mean, it's almost, you have to use massive numbers of patients. But if you select patients, for instance, with heavy calcification in the coronaries who are yet not classified as patients, they're not secondary prevention because they never had an event, but we know they have atherosclerosis, and we know they have something that's going to prevent those. You could focus your studies on those populations and solve many questions. So part of what we're looking for in any of our publications is novelty. We like to see new things. We want it to be accurate, and we want it to be clinically relevant. Mm-hmm. Although we do take preclinical papers that generate hypotheses for other research, and we're very interested in the broad field.
Thank you for your answer today.